Dear colleague, dear friends, it's a great pleasure to welcome you to this new podcast organized by HIHAT as part of the educational activities. Well, the purpose of this podcast is to give you a flavor of our recent program focused on von Willebrand disease. And today I have the great privilege and honor to welcome Professor Sophie Susen. Sophie, hello.
Hello, Cedric. Hello, everyone.
Thank you. Thank you for taking the time to join us. I know you are quite busy. And what we would like to do now is to discuss a topic that you really like, you really love. You are quite interested in this, which is the management of the gastrointestinal bleeding in patients with von Willebrand disease. So a question I would like to ask to you is, how did you get interested in that specific complication over the last few years?
Because it's the most challenging situation in von Willebrand disease. I mean, it's not so frequent, but it's always challenging. And we have to discuss with other specialties, such as gastroenterologists, which is something sometimes difficult. And so that's why I think it was useful to provide some guidances at first in my hospital, and then we applied those guidances in a nationwide fashion.
Okay. And in terms of prevalence, so demography of this GI involvement and complication of von Willebrand disease, is that something that our colleagues should frequently encounter in their practice, or what's the prevalence?
So the true prevalence is has been studied by the Swedish group. And what we should keep in mind is that GI bleeding is the first cause of hospitalization in the general population, and it's increased by tenfold in von Willebrand disease, whatever the type of von Willebrand disease. So it's frequent in the general population, and it's more frequent in von Willebrand disease.
And if I understand well, these patients can present with spontaneous bleeding from the GI tract.
Yes, and there are a lot of presentations. They can have just iron and anemia. They have life-threatening bleeding. All the causes of GI bleeding can be present in von Willebrand disease, but there is a specific lesion which is called angiodysplasia. It's an abnormal development of vessels in the GI tract, which is more frequent in von Willebrand disease, inherited and also acquired. But today we are talking mainly on inherited von Willebrand disease.
Well, I know that in your lecture you gave plenty of details and a lot of information from the literature from your group and other groups, but just to inform our practice, when should our colleague think about this complication in our patients? So they meet patients with von Willebrand, or they suspect von Willebrand. So when should they suspect that the GI tract could be involved?
You mean with angiodysplasia?
Yeah, and yes.
Well, angiodysplasia is often presenting as melena or anemia, which is a very frequent symptom. And in case of severe von Willebrand disease, meaning type 3 or type 2B, all the types that are lacking high molecular weight multimerase or are very severe, an extensive exploration of the GI tract should be performed at least after the first episode of GI bleeding. We are working on that.
Yeah, and in terms of what sort of investigation should ideally be performed? So if you want to summarize, what would be the optimal approach in terms of diagnosis and endoscopy and so on?
Yeah, of course, there are all the exploration that should be performed like in the general population, meaning gastroscopy and colonoscopy. And sometimes the cause of the GI bleeding is evident and you don't need to go further. But very often, and in particular, in case of recurrence of GI bleeding, you need to take all the means to identify the lesion. So the video capsule, PillCam, which is swallowed and allows to document the small bowel and all the GI tract should be performed. And it's very important to have in mind that in a few couple of years, it will be very easy because it will be analyzed with artificial intelligence, and it will be very easy to have a total imaging of the GI tract. But now it's not like that, so you have to convince gastroenterologists to do this video capsule examination. And what could be done is also angio-CT scan, because while the patient is bleeding, it doesn't require any special preparation of the GI tract, and you can have the direct imaging of the bleeding. Of course, it doesn't allow to treat the patient locally, but at least it gives you the localization of the bleeding.
So these are tests that you classically perform in your center to investigate these patients. And so these angiodysplastic lesions, so they are present in a normal population without von Willebrand, but what's their, if you take your experience and the French population, so in patients with von Willebrand, what percentage of them could have angiodysplasia? Any idea about this?
It's not so evident to give a precise number, because we performed a survey, and that the survey does not provide any information on true prevalence. It was, of course, there is a referral bias for that. We can say it's rare, angiodysplasia, more frequent in type 3 and in type 2A and type 2B, but still can be present in type 1 and in other types of von Willebrand disease. And what's really important to have in mind is as the moment when you identify a patient with angiodysplasia and von Willebrand disease, it will have a recurrence in half patients will have recurrences. So you must follow this patient in your center. You must have news about him, and you must maybe find a gastroenterologist who will be in charge of this patient, and will plan with you all the exams that will be important to perform in case of recurrences.
So an important message for our colleagues is that not only type 2 and type 3, but also type 1 could be concerned by this, because I think this is one of the main findings of the study you conducted.
Yeah.
So this is an important.
Even it's lower frequency, it can happen.
Okay. And in terms of pathophysiology, because I know this is a topic you are interested in. So why do these patients with von Willebrand disease develop this kind of lesion? What would be your hypothetical, pathophysiology? So things that we know and maybe we do not know.
Okay, I think there is a lot we don't know, but what we know is that there may be an impairment of angiogenesis in those patients. Anna Randy provided a lot of scientific evidence to document the link between von Willebrand factor, angiogenesis, and wound healing repair. It's not so evident to have a unique pathway. Maybe it's linked to the VEGF pathway. Maybe it's the high molecular weight multimerase defect per se, meaning that the platelet adherence to the vascular wall that is involved. Maybe it's the fragments of degraded VWF is involved. We don't know. Clearly, we don't know. There are a lot of hypotheses, but there are no accurate models, no animal models. There are experiments that are ongoing on gut-on-chip models, which maybe will provide some new evidence. But what we can say is that at least there is an impairment in angiogenesis, and that in those situations, that is also observed in patients with aortic stenosis and ventricular assist devices and ECMO, which have also acquired von Willebrand syndrome, is that maybe the frontline therapy is more anti-angiogenics than von Willebrand factor replacement. But until now, in those patients, sometimes we begin prophylaxis. with von
And
Willebrand factor.
do you think there is any, well, if there is a big of difference between the acquired von Willebrand disease and congenital von Willebrand disease in terms of angiodysplasia generation? So we know that, and you studied a lot this patients with aortic stenosis, ECMO, and so on. So they also lose their multimers. So do you think that the mechanism are more or less involved, or are they more specific for acquired?
Maybe for acquired, the first hypothesis could be, and it has been shown by a group, that proteolytic fragments could be toxic, let's say, for the vascular wall of the GI tract. And on top of that, the flow in the vascular bed is impaired in those situations, which is not the case for von Willebrand disease. So maybe there are different pathways that are combined, and there is a triggering event, and on top of that, other events. So I think it's not an easy picture to describe.
Okay, but clearly an area where our younger colleagues should certainly invest time in terms of research and well, you said that VEGF could is involved. So do you think that there could be any role for VEGF assay?
Yeah, yes. If we look at what was performed in another situation, telangiectasia, where the treatment of anti-VEGF bevacizumab was quite successful to reduce the bleeding symptoms, maybe there's something to do in von Willebrand disease patients. With that, but again, until now we only have case reports. But the efficacy of such a treatment could also prone for a role of the VEGF pathway in the occurrence of those vascular abnormalities.
Okay, so let's now move to the treatment. So how can we really help this patient who have this angiodysplasia, and we know this is a major complication for them? With a major impact on their daily life and things like that. So what would be the ideal treatment approaches of these patients?
The first step is to identify the lesion and where and the localization of the lesion. First, because what we've seen in our survey is when you have a small bowel angiodysplasia, you already know that there will be an increased risk of recurrence. And so you will have to explain to the patient all the signs and so on. And you will have to discuss with the gastroenterologist, okay, we are treating this first episode, but let's decide what we will perform in case of recurrence. So I think that's very important for the patient at first, because he will be more adherent to the treatment when you explain what's going on. So the first is identify the localization of the lesion, and if possible, to treat with plasma argon, meaning that there is a special access with endoscopy to treat locally the lesion, and it's the best treatment for those kind of lesions. But sometimes you don't identify the lesion, or you have the idea to treat lesions that are not bleeding. So sometimes you need to introduce prophylaxis, which we know that it is much more less effective than for other bleeding symptoms. The odds ratio for efficacy is much less than for hemarthrosis or menorrhagia, for instance. So it's not the best option.
But this is something you would recommend. You would recommend these patients to be on prophylaxis
in case of recurrence after the local treatment.
Yeah, and in terms of well, we know that in this big family of von Willebrand factor concentrate, we have different products. We have dual concentrate, we have monoconcentrate, or we have even no recombinant von Willebrand factor. Any preference?
So in case of severe von Willebrand disease, in which factor VIII levels are low, for the first infusion, I'm not talking about prophylaxis, but an acute bleeding, you need to provide some factor VIII for the first infusion. So it can be a solution to have a dual concentrate. But for prophylaxis, there is no preference in terms of plasmatic concentrate. I mean, you can use dual or pure VWF concentrate. it has been hypothesized that recombinant von Willebrand factor concentrate containing high content of very high molecular weight multimers could be a treatment option, a better treatment option in those patients. Well, it has not been demonstrated yet. What we can observe with this treatment in case of prophylaxis is that sometimes the half-life of factor VIII and of VWF is longer than with plasma-derived. So I don't know if it increased the efficacy in case of prevention of recurrence of GI bleeding, but still sometimes the half-life is better.
Okay, well, I think we are now close to the end of this discussion. Maybe you have 2 or 3 take-home messages that do capture your presentation.
Well, know your gastroenterologist well. Invite him to take a coffee, discuss about your patients, and be keen with him or her, because you will have to be in contact very often, and you will have to treat locally the patient. So they should be on board. And after that, there is a lot of research to do, and we will have to combine our efforts in a European way to collect all the observation and maybe to build some new studies on the European level.
Thank you. Well, yesterday we emphasized in another podcast the importance to interact with the gynecologist, and today we emphasize the critical aspects of having good relationships with our colleague gastroenterologists. So, Sophie, thank you very much again for contributing so actively to this education program. Your presentation is great. It's a unique overview of this very important topic, and I invite all our colleagues and friends to watch it very soon. Thank you, and see you soon.
Bye-bye.
Bye-bye.